Hey everybody, so welcome back to another easy EKG video. I've been pretty busy with residency starting up, so I apologize that I haven't been more active on the channel, but I hope to change that here over the next couple of weeks. So keep your thoughts and questions coming, and I'll do my best to answer them in a timely manner. So today's topic, and it's a topic that I've been asked a lot of questions about recently through your messages, is talking about how do you recognize an ST elevation myocardial infarction. That's what the STEMI stands for. So we're going to go over some of the kind of things to look out for and do's and don'ts, just kind of the basics of, if you're working late in an ER, in the middle of nowhere, and you're trying to figure out, is my patient having a heart attack or not? So let's get to it here. If I can advance the slide. There we go. So first thing, in order to diagnose an ST elevation MI, you need to be able to recognize a normal EKG. So I have other videos that kind of talk about the 12-lead EKGs and then the 6-lead EKGs, and those are probably pretty important to know before you kind of watch these videos. So just to summarize, so remember we have lead 1, lead 2, and lead AVF. As well as lead 3, AVL, and AVR. Those are the main 6 leads that you're going to see on a 6-lead EKG that you have in like the ER that you're going to be hooked up to onto a monitor. And then you have V1 through V6, which are the precordial leads, which are going to give you the direction of the electrical activity from a front to back. And remember, these 1, 2, 3, AVR, AVL, and AVF are the electrical activity from a top, like your head, down to your feet. So 1 through AVF is head to foot. V1 to V6 is kind of like you're shooting a gun through the chest. It's anterior to posterior electrical axis. So with the EKGs, remember we got the P wave, QRS, and this is a completely normal EKG. The rhythm is sinus. And the rate, let's see, so 300, 150, 100, 75, 60, so it's about 65 or so. So pretty normal. So let's go to the next one, which is not going to be normal. So let's identify first what an ischemic endocardium looks like on an EKG. So this is what they call ST depression. So remember we got our P wave, our Q, R, S, and then here's the T. So from here to here, the S to the T is depressed, right? That's why it's down below your isoelectric point, which is this line, which is kind of the baseline. So whenever you see this going down, that means that the cardiac tissue is not dying, but it is hurting for oxygen. Okay, so it's important to be able to recognize ischemic from infarcting. So this is infarcting endocardium. So remember we had the P wave, then we have our Q, R, and then our S to the T. So here we have the ST is elevated, which remember the STEMI, ST elevation MI. So that is what we're seeing when we're having cardiac tissue that's dying. So this is a medical emergency. This is not. This is something to be like, this is bad. We need to figure out why he's having this, but he's not going to die from this immediately. This is going to kill a patient, so we need to recognize and treat this very quickly. The other thing you can kind of see, so his T waves are inverted, which is also another sign that you could have some sort of cardiac acute event that's happening or that has happened before. So you want to keep an eye out for your T waves as well. So let's go on to the next EKG. So this is what you're going to see at 2 in the morning of your patient who comes in with chest pain. They just couldn't get to sleep. They were kind of sweaty and they felt sick. So you get this EKG, your nurse or your paramedic, or whoever hands it to you, or you take it as a paramedic, or you're looking at this and you're like, okay, what's going on? So his rate looks okay. You immediately are drawn to the precordial leads and you see that, oh my God, he has elevation in 1, 2, 3, 4, 5, and doesn't have anything in 6. So he is not doing well. So this would be a cardiac emergency. You would call the code 1. You would call the helicopter if you're out in the middle of nowhere, or you would call your cath lab team if you are in a metropolitan area, and they would ideally take this patient to the cath lab in under 30 minutes. That's typically the standard. A lot of places actually can do it in under 15. Some of them can even just bypass the ER completely. If you're in a paramedic situation that is able to transmit EKGs, so they can just go straight in, right through the ER, right to the cath lab, and get the balloon and stent in the cardiac or in the coronary arteries real quick. So let's look here. So V1 is elevated, V2 is elevated, V3 is elevated. So these are the anterior leads. V4, V5, V6, those kind of wrap around the side. So these are kind of the lateral leads. So this would be an anterior, probably an anterior, maybe septal. I'd say anterior, and then it kind of reaches around into the septum. So you can kind of think as this is like 1 and 2 are anterior, 3 is kind of septal, 4 is kind of septal. They're kind of blended together, and then 4, 5, 6 is kind of the post side of the heart, not the posterior aspect, but more kind of around by the septum. So this would be an anterior MI, is what I would diagnose this as. Let's go on to this one. So you get this one in the middle of the night, and you are looking, you're like, oh, it doesn't look too bad. He's got some elevation in 1 and 2, but he also has some depression in 1, 2, 3, and maybe a little, and some elevation in 6, little in 5, maybe depression in 4. So you're kind of like, what's going on here? So, you know, he's got just kind of weird looking ST elevation. So he's got it in 1 and 2, and he has it in 6, and maybe a little bit in 5. So, and a little bit in F, yeah, a little bit in F as well. So you're trying to figure out, okay, where is this guy having an MI? Well, actually, this is a trick question. So this is what we call a posterior infarct. And more than likely, this is a posterior inferior. Why? Because remember, these V1, V2, V3 are the anterior leads of the heart. So they're on the front of the heart. So if you think about it, if it's like a mirror image, if these are on the front of the heart, what are the electrical axis, or what's the electrical rhythm going to look like on the back of the heart? So if we held a mirror up to this on the back side of the heart, V1, V2, and V3 are actually going to be elevated. They're going to be ST elevations. It's depending on how you're looking at that specific electrical depolarization. It's kind of tricky, but it's something that's very, very important to be able to recognize, because someone might see this in 1, 2, and 3. If everything else was normal and they just had depressions in 1, 2, and 3, they might be like, I don't really think anything's going on. He might just have some ischemia. But in reality, he could be having a massive right-sided infarct. So what are you going to have with a right-sided infarct? You're going to have low blood pressures. That's kind of the number one thing that you'll see, in addition to the rest of the cardiac symptoms. But how are you going to treat this? So you're out in the ambulance. Are you going to give this guy nitro? And the answer to that is no. You never want to give any nitroglycerin to anybody who's having a posterior MI or an inferior MI. And the reason why is because the heart, when they're having a posterior MI, is depending on the preload. So what does that mean? So the preload is, this is a little heart thing I stole from online. I didn't make this. I'm not an artist at all. But the preload is how much blood is actually getting pumped into the ventricles, the right side of the heart, the right ventricle and the right atrium, without having to have the right atrium or the right ventricle pump. So it's like if we're turning off this side, if we're just completely removing the right side of the heart, so we get rid of this part and we just have this being a hollow opening, how much blood can the left ventricle pump after it pumps it all the way through the body, all the way back up the inferior vena cava and into the right atrium and the right ventricle, and then into the lungs, and then back to the pump? So essentially, if we give nitroglycerin, we're going to vasodilate everything, and we're going to decrease the amount of blood that we're pushing into that right side of the heart, correct? So if we decrease the amount of blood that's getting pumped into the right side of the heart, we're decreasing the amount of blood that can be pumped totally. And remember, the vessels that perfuse the heart are at the aorta, at the very, very beginning of the aorta. So if we're decreasing the amount of blood we're able to pump, we're decreasing the amount of blood that we're getting into the heart, which decreases the amount of cardiac cells that are going to survive if you do make it out of this heart attack. So no nitroglycerin if you're having an inferior or a posterior MI. And why is it an inferior MI as well? Because most of the times when you have an inferior MI, it includes the posterior part of the heart as well. So that's why they say no nitro with posterior or inferior MIs. Let's go to another one. So here's another posterior MI. Remember we have our ST elevation looks like in 1, 2, and then we have depression in V1, V2, V3. And then they actually went around and they swapped. They put the V4, V5, and V6 on the back of this patient. So V1 is the front version of V7. V2 is the front version of V8, and V3 is the front version of V9. So if you can kind of imagine, if you take this and you flip it over, it's going to look like that. If you take this one and you flip it over, it looks like that. And if you take V3 and you flip it over, it looks like this. So this is documenting that, hey, we're having a posterior MI. This is important. We need to call the cath lab. So that's what it will look like if you do go ahead and put the posterior leads on, which they can do, but they don't really make machines that have, 15 lead EKGs anymore. It's just not practical. So here's another one. I should have deleted this little thing up here. I'm sorry. Here, I can just do that right now. Look at this. We're editing on the fly. Perfect. Done. So here's another one. I'll let you kind of look and tell me what you think is going on with it. If there is anything wrong, this could be completely normal. So you have 10 seconds to look at it because that's as much time as you'll get in the real world. All right, time's up. That wasn't 10 seconds, but that's okay. So again, you look, V1 looks good, or excuse me, lead 1 looks good, 2 looks good, 3 looks good, AVR looks good, AVL is good, AVF is good. We look at the precordials, and we notice right off the bat we have T-wave inversion in V1 and V2, which sometimes you can have it. It's considered to be kind of normal if it's in V1, but V2, not so much. We have a little bit of this downward dip in V3. We're going to call this ST depression, and we have ST depression in V4 as well. So ideally we would check cardiac enzymes on this guy to confirm that he is having a heart attack, but this actually is a posterior MI. And we would be able to see that when we get the reciprocal leads of the V7, V8, V9, which we have right here. So what they actually did is they moved things around, so they got rid of V1, V2, V3, and they put them as V4, V5, V6, and then put V4, V5, V6 as V7, V8, V9. So V4 we have depression, V5 is equal, V6 is equal, V7 we have some elevation, V8 we have elevation, and V9 we have elevation. So this is also a MI that we need to get taken care of. This is a posterior MI, so we don't want to give any nitro. That's very important. And I got to do another edit on the fly here, guys. Sorry, it's 11:30 at night. So, all right. So now here is a different EKG, and this is the last one in this video. I want you to tell me what you think's going on here. You give 5 seconds. Time's up. So what this is this is a left bundle branch block. There is no pathologic cardiac event happening here that we can see with like ST depressions or things like that. But if you have a new developing left bundle branch block in a previously otherwise healthy adult or child for that matter, this is a ST elevation equivocal. This is an MI equivocal or equivalent. So what it means essentially, if you have a new documented left bundle branch block in the episodes of chest pain, this is considered to be the patient is having an MI. That is the rule with this. And you can tell that this is a left bundle branch by, if you look at the QRS complexes, they're wide. They're wide down here in the precordial leads, and you notice there's no R wave progression at all. You can also tell that the conduction pathway is not left to right as it should be. It's actually right, and it's going around the fascicular branches and then into the left side. So it's kind of going backwards. So that's a left bundle branch block, and I have more info on that in the other videos. So this is a MI equivalent, and you need to call the cath lab for this as well. So I hope that these slides have helped you. As always, if you have any questions, feel free to shoot me an email, and I will do my best to get back to you. Thanks for watching. Have a great night.